Welcome to the clinical refresher for radiography of the patella. This module was written by Susie Mosley, BS, RTR, and Megan Lemp, BA, BA. After completing this module, you will be able to describe the patient preparation requirements for radiography of the patella, explain how to position a patient for a patella examination, summarize the technical settings and patient instructions necessary to produce a diagnostic image, identify major structures seen on patella radiographs, list the evaluation criteria used to determine image quality. Examinations of the patella typically include PA, lateral, and tangential projections. There are several methods of performing a tangential patella projection, including the Houston, Merchant, and Settegast methods, with varying patient positions and central ray angulations. The method used generally depends on departmental protocol, physician preference, and the patient's condition, and often both patellae are imaged for comparison. Clear communication with the patient will ensure that a proper patient history is acquired and that the patient will comply with all instructions. It is generally good practice to explain the procedure to a patient before exam positioning so that any questions can be answered immediately. Patient history includes a discussion of any known anatomical variants that may impact the exam, as well as any medical devices implanted in the area of interest. For example, technical factors will need to be adjusted if a patient has a joint replacement or severe arthritis. Patients must remove all clothing in the area of interest. If needed, patients are provided with a gown for privacy and to prevent the patient from getting cold. A PA projection of the patella generally is preferred over an AP projection because it positions the patella closer to the image receptor, thus improving detail on the finished radiograph. Positioning for the PA patella projection begins with the patient prone and the affected leg extended. If the patient is in pain, place a thin positioning sponge under the thigh and lower leg to take pressure off of the patella. The image receptor is centered under the patella. Rotate the patient's leg and heel slightly until the patella is parallel with the plane of the image receptor, typically 5 to 10 degrees laterally. The central ray is directed perpendicularly to the mid-popliteal area and exits through the patella. Anatomical markers are placed on the image receptor to identify the anatomical side that is being examined. The patient's gonads are shielded, and the shield is placed between the X-ray source and the patient. Instruct the patient to hold very still, but no breathing instructions are necessary. An 8 by 10 inch or 18 by 24 centimeter image receptor is used for a PA patella projection and is adjusted lengthwise. If this size is not available, a 10 by 12 inch or 24 by 30 centimeter image receptor may be used. The SID is set at a minimum of 40 inches, although some departments may require a longer SID. Collimation is adjusted to approximately 6 inches by 6 inches or 15 centimeters by 15 centimeters and must be close to the patella. 85 kVp is a common setting for a PA projection, especially if a grid is used. Automatic exposure control may be used to achieve the proper mass setting for a PA projection. However, common mass settings are 3.2 mass when using digital radiography and 6.3 mass when using computed radiography. A small focal spot is selected. The PA projection shows the entire patella, which is superimposed on the femur. The following quality criteria are used to determine if a PA patella radiograph has been produced with proper positioning and technical factors. Collimation does not obscure relevant anatomy. The femur superimposes the patella completely, and brightness and contrast are sufficient to clearly visualize the patella through the femur. The patella is not rotated, and there is adequate demonstration of soft tissue and bony trabecular detail. Positioning for the lateral projection begins with the patient lying on the affected side. Draw the unaffected leg forward and rest it in front of the affected leg. If needed, use a sandbag or positioning sponge to support the ankle of the affected leg. Have the patient flex the affected knee slightly, between 5 and 10 degrees. Note that a greater degree of flexion will result in narrowing of the patellofemoral joint space. The image receptor is centered to the patella. Adjust the patient's body position until the patella is perpendicular to the plane of the image receptor, and make sure the femoral epicondyles are superimposed. The central ray is directed perpendicularly and enters at the midpoint of the patellofemoral joint. Anatomical markers are placed on the image receptor to identify the anatomical side that is being examined. The patient's gonads are shielded, and the shield is placed between the X-ray source and the patient. The patient is instructed to hold very still, but no breathing instructions are necessary. An 8 by 10 inch or 18 by 24 centimeter image receptor is used for a lateral patella projection and is adjusted lengthwise. If this size is not available, a 10 by 12 inch or 24 by 30 centimeter image receptor may be used. The SID is set at a minimum of 40 inches, although some departments may require a longer SID. Collimation is adjusted to approximately 4 inches by 4 inches or 10 centimeters by 10 centimeters and must be close to the patella. 85 kVp is a common setting for a lateral projection, especially if a grid is used. Automatic exposure control may be used to achieve the proper mass setting for a lateral projection. However, common mass settings are 2 mass when using digital radiography and 2.8 mass when using computed radiography. A small focal spot is selected. The lateral projection shows the patella in lateral profile and demonstrates the patellofemoral joint space. The following quality criteria are used to determine if a lateral patella radiograph has been produced with proper positioning and technical factors. Collimation does not obscure relevant anatomy. The patella is seen in lateral profile. There is correct 5 to 10 degree flexion of the knee, and the joint space between the patella and femur is open. There is adequate demonstration of soft tissue and bony trabecular detail. Positioning for a tangential projection using the Houston method begins with the patient in the prone position with the affected leg extended. Make sure the patient's body is not rotated. The image receptor is positioned under the femoral part of the affected knee. Have the patient flex the knee until the tibia and fibula form an angle of 50 to 60 degrees with the plane of the table, and use a support device to help the patient maintain this position. If the surface of the collimator is not hot, the patient may rest their foot against it to support the leg. Adjust the position of the leg to make sure there is no medial or lateral rotation. The central ray is directed at a 45-degree angle and enters at the patellofemoral joint. Anatomical markers are placed on the image receptor to identify the anatomical side that is being examined. The patient's gonads are shielded, and the shield is placed between the X-ray source and the patient. The patient is instructed to hold very still, but no breathing instructions are necessary. A tangential projection using the Merchant method can be performed to obtain a bilateral image of the patellae. Positioning begins with the patient seated at the end of the radiographic table. Both knees are positioned at the edge, and the legs are secured on a specially designed, adjustable image receptor holder and support device. Adjust the position of the patient's knees until the femurs are parallel with the plane of the table, and flex the knees 40 degrees. If a designated support device is not available, a tabletop image receptor holder can be used, and a similar patient position is achieved with the patient lying supine. Both knees are flexed 40 degrees, with the soles of the feet resting on the radiographic table. Although 40 degrees is common, varying degrees of knee flexion can be used to demonstrate particular disorders of the patellofemoral joint. It is important to note what degree is used so that it can be reproduced in future examinations. Make sure the patient's legs are properly supported and relaxed as much as possible. Subluxation of the patella may not be evident on the resulting image if the patient is unable to relax their leg muscles adequately. Support the patient's head and back with pillows or a positioning sponge to aid in relaxing the quadriceps femoris muscle. Position the image receptor on top of the patient's shins, approximately 12 inches distal to the knees, and make sure it is perpendicular to the central ray. The central ray is angled toward the patellae until it forms a 30-degree angle with the femurs. When the knees are flexed 40 degrees, this is accomplished by angling 30 degrees caudal from the horizontal plane. The central ray enters at a point halfway between the patellae and at the level of the patellofemoral joints. Anatomical markers are placed on both sides of the image receptor to identify the anatomical sides being examined. The patient's gonads are shielded, with the shield placed between the X-ray source and the patient. The patient is instructed to hold very still, but no breathing instructions are necessary. A tangential projection using the Settegast method can be performed with the patient seated, prone, or in a lateral recumbent position, although the prone position is generally preferred because it allows for a greater degree of knee flexion. Before this projection is performed, a lateral image must be obtained to rule out a transverse patella fracture. If a fracture is present, positioning the knee in acute flexion as required for this projection could cause fragment displacement. This projection also may be difficult to perform when the patient is in severe pain. If acute flexion is not contraindicated, slowly flex the affected knee until the patella is positioned perpendicular to the plane of the image receptor. In the prone position, the patient can use a long strap or bandage looped around the ankle to hold the leg in place. Using slow, smooth movements to position the knee will help the patient tolerate the exam. Position the image receptor under the knee and center it to the patellofemoral joint. If the patient is in a lateral recumbent or seated position, make sure they are able to hold the image receptor firmly in place and that the correct OID and SID relationships are maintained. When the patella is perpendicular to the plane of the image receptor, the central ray is directed perpendicularly to the patellofemoral joint. When a perpendicular position cannot be obtained, the degree of knee flexion is used to determine the central ray angulation. An angle of 15 to 20 degrees is common. Anatomical markers are placed on the image receptor to identify the anatomical side that is being examined. The patient's gonads are shielded, and the shield is placed between the X-ray source and the patient. The patient's thyroid and upper body also are shielded if the central ray is directed toward the thorax. The patient is instructed to hold very still, but no breathing instructions are necessary. An 8 by 10 inch or 18 by 24 centimeter image receptor is used for a unilateral tangential patella projection and is adjusted lengthwise. A 10 by 12 inch or 24 by 30 centimeter image receptor is used for a bilateral patella examination and is adjusted crosswise. The SID is set at a minimum of 40 inches, although some departments may require a longer SID. It is recommended to use an SID of 6 feet or 2 meters when performing the merchant method to compensate for the increased OID and reduced magnification of the patellae. Collimation is adjusted to approximately 4 inches by 4 inches or 10 centimeters by 10 centimeters for a unilateral examination and must be close to the patella. Collimation for a bilateral examination is adjusted to approximately 4 inches by 10 inches or 10 centimeters by 24 centimeters. 70 kVp is a common setting for a tangential projection performed without a grid. Common mass settings are 2 mass when using digital radiography and 4 mass when using computed radiography. A small focal spot is selected. A tangential patella projection will demonstrate subluxation or fractures of the patella. It also is used to evaluate the patellofemoral joint and the femoral condyles. When the merchant method is used, both patellae are included on the image and are slightly magnified. The following quality criteria are used to determine if a tangential patella radiograph has been produced with proper positioning and technical factors. Collimation does not obscure relevant anatomy. The patella is seen in profile, and the patellofemoral joint space is open. The medial and lateral femoral condyles and the intercondylar sulcus are well visualized. There is adequate demonstration of soft tissue and bony trabecular detail. This concludes the clinical refresher for radiography of the patella.